Welcome to episode 5 of the TVN Together 7 Things You Need to Know About Pressure Ulcer Prevention. Now, I'll shortly hand you over to Julie and Shona, who are going to discuss the importance of managing continence and increased moisture on the skin in the prevention of pressure ulcers. Now, Julie Glendewar is a tissue viability clinical nurse specialist for family nursing and home care from Jersey in the Channel Islands. And Shona McShane is a tissue viability nurse for Western Health and Social Care Trust, Northern Ireland. Over to you, ladies.
Thank you, Jenny, and welcome to the Eye for Incontinence segment of the TVN Together series on the 7 things you need to know on pressure ulcer prevention. Today, both myself and Shona will discuss the impact of incontinence and moisture on pressure ulcer development and how to help prevent it. So today's session is aimed at anybody who is having problems with incontinence. This can include, or anybody caring for somebody who is suffering from incontinence. This can include informal carers, family members, trained nursing staff, allied health professionals, or even a friend. Actually, anybody who may be interested or think that this session may be useful, please join in. You may be living in your own home, you may be in a care home with 24-hour support, or in hospital. You may or may not have a continence problem at the moment, and you may or may not be at risk of developing a pressure ulcer at the moment, but the information we're providing today will give you some insight into who to contact should you experience problems or develop a pressure ulcer. We will look to discuss the risks of pressure damage as a result of incontinence or moisture, so that you can identify if you or the person you're caring for is at risk, and how to identify those risks before they become a problem. We will hopefully illustrate to you the normal function and structure of the skin and the effects of moisture on the skin, and clear up how this disruption to the skin can result in pressure damage. We will advise you when and how to assess the skin before exploring with you how to protect the skin from further damage, and hopefully ensure that you know how to prevent or treat any damage before a pressure ulcer develops while you're still at the stage of having incontinence related problems. So, brief explanation. So, individuals with continence problems are more likely to be less mobile and elderly. This is for a variety of reasons. Mostly it relates to the muscles and the bladder. So the muscles in and around the bladder as you get older may lose tone, which means they get weaker and they can't hold the urine in as well. So you might get some stress incontinence. The muscle also, when it's not contracting as well, may not empty completely, and the sphincter in our bladder that controls that may not close properly, which allows leaks to occur, and that will cause that sort of little dribbling incontinence. We also have a reduced bladder capacity as we get older, which means it doesn't hold as much before we get the urge to go and pass urine, and that trigger, because of the change in the bladder capacity, occurs quickly and more urgently, so you might not have the ability to actually get yourself to the toilet as quickly as you would normally. For us ladies, as we go through menopause, the hormone changes affect the tone and ability of the bladder to work as effectively, so that's another thing to contend with. The older we get, the more likely we are to have problems with our mobility, and that can impact on our ability to manage our continence effectively and suffer from incontinent episodes. Lots of people as we get older need medication for various reasons, and quite often we find that diuretics are used. The aim of a diuretic is to produce more water, which in turn produces more urine, which can increase the risk of developing urge incontinence. Sedatives as part of our medication can also slow down the signals from the bladder to the brain, and that again can increase our risk of becoming incontinent, and quite often it is just because we don't get that ability to get to the toilet at an appropriate time, which means we can need to rely on incontinence pads or products, and the use of those has its own risks. The other issue with sedatives are they can cause some confusion, and again that can impede on our ability to get to the toilet at an appropriate time or recognise that we need to go to the toilet. Some of the fluids we drink can increase our likelihood of developing incontinence. So caffeinated drinks and alcohol, and that causes stress incontinence. So we need to be aware that when we are encouraging fluids that we maybe look at decaffeinated options or try and stick to plain water if at all possible. Dementia and some other chronic health conditions obviously impact on normal body function. So chronic conditions such as arthritis, obviously the dementias, Parkinson's, can result in incontinence being a problem. We can get a combination of different types of incontinence. So urge incontinence, where you need to go now. Stress incontinence, where you can't actually hold the urine in your bladder. Functional, where you can't get to the toilet on time because of maybe mobility issues or other problems. And you get a neurological component where your brain doesn't actually communicate effectively with your bladder. So the messages aren't going through properly. And again, that can cause a problem leading to incontinence. And you can have a combination of one or more of those types of incontinence at the same time. So by knowing what the cause of the incontinence is, you can then work on the most appropriate intervention to help manage it. You may need to be referred through to the continence nurse specialist or the urology department to help support and get a diagnosis for those conditions. So obviously problems with moisture and continence increase our risk of developing a pressure ulcer, and also incontinence associated skin damage and pressure ulcers can coexist. We need to look at how we can reduce those risks through effective and appropriate skin care, and by reducing the pressure to those bony areas, reducing potential friction and shearing, and management of lifestyle factors that are associated with causing or increasing our risks. So next, who is at risk? So anybody is potentially at risk of developing moisture associated skin damage, and that in combination with a pressure ulcer increases more so when you are looking at people with vulnerable skin. Again, that falls into the older age category because as we get older, our skin gets thinner. Obviously, anybody who is experiencing urinary or fecal incontinence has a higher risk factor. Anyone who is experiencing excessive sweating, and that can be due to a neurological problem or some other type of condition that causes you to sweat excessively, and it's particularly a problem when you are potentially lying down in bed for long periods of time, or in bed where you don't move yourself, or in a wheelchair where you're unable to move yourself. And if you're relying on incontinence products to manage your urine and that you're not going onto the toilet to pass urine, that will increase our vulnerability of our skin. We need to consider how to manage and protect that vulnerability. We're going to talk about that in a little while. So what does too much moisture do to our skin? I've got a little picture there with a diagram of the different layers of our skin, and predominantly in the first instance the damage will occur in the epidermis, where it's the outside bit of our skin, and too much moisture to that area reduces the protective barrier of our skin and increases the permeability, which is its waterproofness. It allows the urine to soak into the skin and giving us that wrinkled effect. Skin may also be susceptible to damage from friction, and friction is where two parts rub together. So that can be your skin against clothing, it can be your skin against a pad if you're wearing an incontinence aid, it could be your skin against the bedclothes when you're lying in bed, or if you're up in a wheelchair against that surface of the chair, the wheelchair, or any other sort of seating arrangement, be it wheelchair, be it your armchair, and that again can cause damage to the skin just by rubbing backwards and forwards. There are enzymes and chemicals in our urine and in our feces that potentially cause damage to our skin. So in urine we have urea, and that will encourage bacteria to grow. And in feces, in our stool and poo, we have enzymes, and again they break down the skin's barrier and allow bacteria or fungal growth to occur. Our skin is quite vulnerable when it's not working as effectively, and as it's the largest organ in our body and its main function is protection, by damaging it through excessive moisture can create a lot of problems for us going forward. We need to look at how we protect our skin and what to look out for. So, when would you assess the skin? As you can see from the slides, we're talking about any opportunity really where somebody can have a look at your skin if you're not able to do it yourself. If you're in a setting where you have care support, be it hospital, with the community nurses in your own home, or in a residential or nursing home setting, that could be the people that are helping care for you. Or as part of a moving and handling assessment, so if you're requiring equipment or aids to help you go to the toilet or to transfer from bed to chair to toilet, that's an opportunity where your skin is potentially exposed and people can check to make sure that it's in good condition if there are any concerns. As part of the assessment, we need to consider nutrition, and are you eating and drinking appropriately? Do you get enough fluids into you during the day? Are you eating a well-balanced diet? Do you eat small and often? Those sort of things to consider, because obviously skin is a living organ, and if we're not well hydrated and well nourished, that can cause increasing problems with the skin. We can assess the skin as part of a meeting to look at our ongoing personal care needs and discuss what will be appropriate, and also as part of a continence assessment. So if somebody's carrying out a continence assessment to work out what type of continence problem you have, they may well ask to have a look at your skin to see what is happening there. And obviously reassessment can take place at each episode of personal care when you're having a review to see if the aids or care that you're receiving is still appropriate, and if you maybe need to have a change in the type of pad you're using or the frequency of change, etc. Or if your condition changes and something else is now affecting you, that will be an opportune moment to determine if there's any ongoing damage to your skin. It doesn't need to be a health professional. Anybody that has access to your skin, that you are willing to allow to look at your skin and have a check to see how it's doing, can carry out this check. It only takes a few seconds, and it is just to have a look and see, is the skin looking sore, red, etc. And I'll show you some pictures shortly about what to look out for. Then we need to think about what happens if the moisture or the incontinence is not managed effectively. And these are the signs that you need to look out for. I've got some pictures on the next slide that will give you a visual of what these words and what these terms mean. But ultimately, your skin may feel moist or wet to the touch and look shiny, and that will be that the urine is sitting on your skin and causing it to be damaged. If it's in contact with your skin for a prolonged period of time and not protected and managed effectively, the skin may look red. And a further development, if it is then not managed, is you can get breaks in your skin. Now these can be linear, which is like a simple straight line type of break, and we call those moisture lesions. And these occur particularly in skin folds, in your groins and your natal cleft, and that's the crease at the base of your back as you go down to your buttocks and around your genital area. And if we get breaks there, they're very difficult to manage effectively, and they can be very sore and uncomfortable. You may then go on to develop a pressure ulcer secondary to that moisture damage, and that's because your skin is already at risk and vulnerable, and that in combination with even just sitting in your chair, resting on your bed, can increase that pressure to that area. And because it's already vulnerable, the breaks occur more rapidly. You may develop a fungal skin infection, so that could be thrush, or another fungal infection from having a warm, moist area, because that area down in your genitals is quite a warm area, and any extra moisture there will cause additional problems. And this results in pain, can cause you distress. It can result in a loss of dignity. People then are checking out your skin in your private area and it can be quite unpleasant for you as an individual having somebody checking you out regularly. And as a result, it can reduce your quality of life and cause you embarrassment. And the last slide that I'm going to cover before Shona steps in is some images of moisture-related skin damage. So you'll see there a range of different levels of moisture damage, going from the initial break and the red skin to a lot of excoriation and a lot of skin damage and redness. And those pictures with the largest amount of damage on, that will be very painful and it's uncomfortable. And the minute urine or feces get on that area, it will increase your pain, it will burn, it will sting and become very unpleasant. And that's what we need to look at preventing before it gets to that point. So if I hand over to Shauna now, she will go forward with the slides.
Thank you, Gilly. So now we're going to discuss the connection between incontinence and pressure ulcers. Research suggests pressure ulcers are 3.7 times more likely in an individual who experiences incontinence. The research further indicates that these patients are more likely to develop more complex pressure ulcers. This is because the structural integrity of the skin has already been compromised by the moisture damage. This area is at higher risk of friction and shear from contact with clothing, bedding, and continence pads, and because the skin has already been damaged by moisture, there is no protection there. The implementation of a structured skincare regime can reduce the risk of developing what we call incontinence-associated dermatitis, or simply put, skin damage caused by moisture. By reducing the risk of developing skin damage, we also reduce the risk of pressure ulcer development by reducing the friction and shear experienced by the body. It is important to note that both conditions can coexist and ensure that when assessing, we accurately identify if both are present to ensure effective treatment of both conditions. So, what do? We can complete an initial assessment, and we should consider if this is new onset of incontinence and the possible reversible causes. This may indicate a need for referral onto the continence service for further support and assessment. This service looks at the issues you may experience to identify steps to help eliminate or reduce incidents of incontinence Gillian has covered earlier in this presentation. This can include scans, referrals onto other services, including urology, special services such as tissue viability, and even district nurses. A review of medications may be conducted to identify any medications which may be impacting on the moisture damage. Appropriate use of aids. A thorough assessment allows you to plan for your needs. This includes proper fitting of pads or aids to reduce the risk of friction or rubbing of the skin, implementing the toileting schedule and utilising alarms as reminders for individuals with cognitive or memory problems. Consider referral to the occupational therapist to assess for equipment such as a raised toilet seat, a chairlift, or even a portable commode, and consider referral to a physiotherapist for any mobility aids. Skincare and the use of barrier products. The presence of incontinence itself should trigger a structured skin care regime to prevent and treat any moisture damage present. Skin should be cleansed daily and following any exposure to moisture. It is recommended to use a pH neutral cleanser. Your standard soap should be avoided as this is alkaline and can cause further damage to the skin. Special attention should always be paid to any skin folds and creases to ensure that this area has been thoroughly cleansed and dried. You should gently pat the area dry and try to avoid rubbing, which can cause extra friction. Speak to your nurse or GP if you identify any skin issues like those discussed by Gilly. Skin barrier products expel moisture and protect against chemical and biological contaminants. It can be used in both intact and damaged skin and provides a semi-permeable barrier on the skin, preventing the absorption of moisture. These products should be reassessed at regular intervals to monitor its effect and modifications made if required. The skincare regime should continue even after moisture damage has resolved to ensure that skin integrity remains and this prevents reoccurrence. Cleansers can come in a variety of compositions, so it's important to find the one that is right for you. You should only be used as outlined by the manufacturer and should be discontinued if they cause any irritation or reaction. Help with toileting. This can come in the form of equipment provided by the occupational therapist or physiotherapist, or with the assistance of another person. This can include prompting to use the bathroom, assistance to mobilise to the bathroom, or by assisting with incontinence needs. Your nurse or carers can provide advice on positioning and help with repositioning if required to reduce pressure to the affected area. You may feel that an increased care package or care support is required, and this can be discussed with your social worker. Referral for specialist advice should be sought if there is no improvement within 3 to 5 days, or if a skin infection is suspected. In some cases, they may advise special devices such as urinary catheters, convens, and fecal management systems. Education for you, your family, and carers is essential to preventing and treating moisture damage. Often they are the first to notice changes or warnings in your skin, and it is important that they know what to look out for and when to report it. It is important that detailed explanations are given to you and your family or carers on any products used so that they understand the application and effect of the products. What actions to consider? If we don't address concerns or consider appropriate interventions, the patient will ultimately end up with skin damage such as excoriation or pressure ulceration. Concordance or adherence issues. If you find there is issues relating to concordance or adherence, discuss with the patient why they are not sticking to the treatment you have recommended. Perhaps it is painful or uncomfortable. Perhaps they don't like the treatment. Perhaps they cannot manage to apply or fit it themselves. Often when we explore the root cause of the issue, you can find a resolution. Perhaps there's more education needed or simply a different approach. It is only by identifying the issue that we can come up to a solution together. What can be done to help if this remains an issue? Explore if there's any concerns about capacity to make a decision. Consider the multidisciplinary team or professional meeting to discuss all options with the patient, their family, and all relevant in their care. Safeguarding concerns. Is someone preventing the individual from accessing care or equipment? If you're a nurse or an allied health care professional, you must report this to the identified safeguarding person. You can also raise a safeguarding concern as a family member, an informal carer, or even a concerned friend to any healthcare professional or social worker. Other identified risks. For example, a change in general health such as mobility, nutrition, or hydration can have a negative effect on the individual and their skin integrity. They may experience concentrated urine, difficulty accessing the toilet due to reduced mobility, or an increased reliance on carers or continence products. Malnutrition in itself affects the overall ability to heal and the skin's tolerance to friction and damage. You must document and escalate all concerns, complete a risk assessment, and try to engage the individual in their care. Consider referrals to other appropriate professionals to address these issues. So to quickly recap, we've talked about these points. We've talked about who is at risk of skin damage caused by moisture. We talked about how incontinence affects your skin and the link between incontinence and pressure ulcers. We talked about how and when to assess the skin and how to protect the skin from this damage. And finally, we talked about risk assessment, concordance and adherence issues, safeguarding and other risks. We hope you have found this helpful and will share this with anyone you think may find it useful. We recommend you also view the other videos within this series which further address factors relating to pressure ulcers. If you have any questions on any of the issues raised within the series, please tune in to our Facebook Live session on the 19th of November via the Journal of Community Nursing.
Thank you, Gilly and Shauna. It's really helpful to think about all the different things that we have to consider when optimising continence or increased moisture on the skin. And you're absolutely correct. Occupational therapists and physiotherapists are highly skilled individuals, not only in continence management, but all aspects of pressure ulcer prevention. So please don't forget your allied health professionals. Talking about allied health professionals, join us next week for episode 6, where Alison and Karen will be discussing the importance of nutrition in pressure ulcer prevention. See you next week.